Can I just have a little comment for Dr. Young? I am probably as old as your father. I have learned with time that, as the Latin proverb says, in medio stat virtus, the virtues start in the middle. There is a place for total, there is rarely place for near total, and there is place for radiosurgery. The reason why you had hydrocephalus in these cases is not because of the radiosurgery, it's because of the radiosurgeon. He did the wrong indication for the wrong size. So doing radiosurgery on a 4 centimeter schwannoma is a neurosurgical crime. This is the problem, it's the indication. And that is why a tumor board is essential. So otherwise.
Okay, first question.
Right, I have a question for Martin. So you used nimodipine tablets, right?
Tablets the day before, and then during the surgery parenterally, and the first day ICU parenterally, and then we continue 5 days tablets.
Okay, so that's different than the Scheller protocol because
A little
Scheller
bit,
is
but
all IV.
yeah. But I think the level of in the blood should be comparable.
Okay, but you did not study the nimodipine itself. You were focusing on the vasoactive peptides or the plasma expanders, with or without?
No, we didn't use the plasma expanders. We did only the nimodipine and the dexamethasone.
Okay, and you said you didn't use antiviral because there is no evidence, or you did a study and compare, and you came up with that it doesn't work or there is no advantage.
It does exist papers, but we decided not to use antiviral because we felt that the evidence for the nimodipine is higher than antiviral.
Because we're looking
the Mayo Clinic that they use this protocol, and then
we're looking
they
at
didn't find any difference.
Antiviral, so we'll see what we find out. And Marcus, just a quick question or comment. You said that for small vestibular schwannomas, the functional outcomes are comparable between radiosurgery and surgery. Did you include also long-term hearing preservation as part of that, or that excluding that?
The study was considering a mean follow-up of 7 years. Yeah, immediately after surgery, the results are better. After 7 years, they are equal. I believe with more period, there is a decline in hearing preservation in radiosurgery, but at least 7 years, they were equal.
Yeah, because 10 years, we have the systematic review meta-analysis and everything about radiosurgery, and it drops down to 24% hearing preservation compared to surgery. So long-term surgery still, there is an advantage there for hearing preservation.
In surgery, you may have hearing deterioration, but rarely you have a complete hearing loss over time. So you may have some hearing deterioration. We have cases like that, but these patients are those who benefit from cochlear implant.
Yeah. Right, thank you.
So I have 3 comments. One, first was the Curitaba group from Brazil. I was shocked at how many surgeons are just chipping away at tumors and not doing anything. And so I guess one question is, I know that we're here in the SAMI meeting and there's so much retro-sig emphasis, but one thing I have seen is that if I go back translab the second time, the scar is minimal, or at least is much easier to deal with because your approach vector has changed. And that was one question. Is that a viable option for some others in the group? Number 2, the comment about radiosurgery versus radiotherapy and size, I think is prescient and very important, because I think actually gamma knife for small acoustics or small volume makes sense. And when I've gone in after single fraction gamma knife, I have not encountered as dense of a scar as when I go in after radiotherapy. So when I go in after 45 or 50 gray of like 5 weeks of radiation, that's terrible. Whereas when I go in after just a single fraction gamma knife, so I think gamma knife, as originally created by Lars Lexell and as pioneered by Dave Lundgren, I think it's it's acceptable because the scar's not as bad and the volumes are tiny what they're treating. They're not trying to treat 30 cc volume tumors. And then third, how do we stop the hack neurosurgeon from doing that approach? What can we do as a society? What options are there? So a lot of complex questions here. Thank you.
Yes, I like to answer about the translab approach because I have tried it, but the problem is not the adhesion to the cerebellum. The problem is adhesion to the brainstem, to the cranial nerves. And I think RET-seq is okay for that because you can see the nerves and dissect it.
But once more about gamma knife and vestibular schwannoma. Believe me that biologically, gamma knife, what is doing? It's not treated that patients. And believe me, they irradiated only small tumor, not growing tumor, and they included like results of gamma knife. It's very, very important knowledge. And we don't need to treat the patients completely. And I follow them 40 years, and according MRI, we saw shrinkage spontaneously. And some of them are not tumor, some vascularized, some it's really not the small tumor, intracanalicular tumor. It's really not tumor sometimes. And it's question. And if they irradiated growing tumor, it's not working. And after surgery, we operate many of them, and it's viable tumor where we found viable tumor histologically.
But you are right. You are right. So also in our series, the majority of the small tumors that had been irradiated, they remained, the majority remained stable, at least at this period of 7 years. The point is, what does it mean? In my opinion, that means we could offer radiosurgery for elderly patients with small tumors. That's true. But not for very young patients because they have many decades in front of them. Yet we have seen that gamma knife in our series worked worse in women and in very young people. So particularly women who become pregnant. So, and this has never been mentioned, discussed. So they consider only tumor size and they do not consider gender, age. And in my opinion, this will be discussed in future probably.
Yeah. I'd like to make also a comment. If you perform radical surgery for vestibular schwannoma, how long should you follow the patient after surgery? In my series, I follow for 5 years. After 5 years, there is no tumor remaining. I consider cure the patient. But with gamma knife or radiotherapy, you have to follow the patient for the rest of their lives.
Another question, gamma knives that they don't know histologically what is it really. Sometimes we operated after gamma knife and it's meningioma, small meningioma. Many of them, and it's they don't know exactly histologically if it is vestibular schwannoma.
One comment is that the problem is, I think, is not Brazil because bad people are everywhere. Bad people. I believe that in US, possibly they are doing more radiosurgery for patients than resecting tumor. But there is a question, there is a very bad joke that we have heard from radiosurgeons that is that gamma knife is better than bad surgery. So my question is, why don't they learn how to do good surgery? They could learn from Professor Sami, from Professor Tatajiba, Amina, and this would be better.
I'm sorry, I didn't want to participate in discussion, but I want to let you to say whatever you believe and They are facts we cannot change around the world. And therefore, we have to accept that we have not the situation like Ramina, Tatajiba, you and you, and everywhere that they can really say, I make a radical total removal. This is the fact.
Yes.
And we have to accept that. I am very proud that I could educate around the world, at least in every country, a couple of colleagues that they are doing similar as Marcus is doing in Tübingen. And I think some sitting here and listening to me, they know that. But now, I assume we are in a city with population of 1-2 million people. And we have some neurosurgeon and some radiosurgeon. And now the question is what we are discussing about about the comparison between radiosurgery and so, but that is not the reality when we are comparing, because we are comparing from whom to radiosurgery. I remember in Pittsburgh, there was a paper came out that they had a better result than the microsurgery. I said to Peter, look, who was doing this surgery that you are comparing the results of vestibular schwannomas and then the radiosurgery? That was unfair and not acceptable, such a comparison. And we should never compare such things because this is not possible. Because what I would like to all you say, please never talk about percentage of anything in neurosurgery because of literature which was published in acoustic neurinoma, 5% liquor as a fistula and 10% facial. That is ridiculous. Who can say that? Nobody, because from one person to the other is the percentage is different. Is that correct or not? Is anybody to say something else? And these facts should be always accepted. I accept all our colleagues around the world that when they start to learn the microsurgery, Dr. Tataji was his first case was preservation of facial and cochlear, because he was 16 years with me and he has seen and learned so intensive this surgery that for him, the first case was always not the first case. And therefore, when somebody as neurosurgeon started, I accept 100% when he is not going to be a radical and total surgeon. We cannot expect that from every neurosurgeon around the world that they have started. I accept that they say, until this part, I am good, but when I go over certain part, then I am going to kill the patient, and I'm going to then destroy facial nerve, I am going to make a lot of problems. This is also fact. We have to accept that. But the message of these gentlemen are sitting here that the goal must be radical total removal. Is that correct?
Yes.
The goal must be. So that I can tell you, for me, I asked myself, how can a neurosurgeon destroy the facial nerve? For me today, it's not acceptable, because you can always follow and found the facial nerve when you have experiences. But I am not expecting that every neurosurgeon around the world is going to make a radical total removal and preservation of. But my advice is we should never compare surgery with gamma knife. You are all right. When the tumor is removed, the patient is cured. When the patient is, you said that, the patient gave gamma knife, the problem is solved. That is a fact. We have to accept this also. But please try to learn this type of surgery from the masters that are existing now in every country. stay time with them, and then start slowly improve yourself. This is in my heart because sometimes you have the feeling now everybody has to do the complete framework. No, it's not possible. This is impossible because I know that even the most experienced, by the way, when you ask me after 5,000 cases, I can say one acoustic is different than the others. Even you will see that anytime you are surprised why the tumor is behaving himself, this is so different that you cannot make a guideline even for the facial. You have to go and stay with the masters who are doing. I'm sorry, I'm talking too much. Thank you.
I'm
Majid,
afraid
Majid,
we ran
Majid.
out of time. Yeah, okay, we ran out of time. I'd like to close the session. I thank the speakers very much.